Ladies and gentlemen, welcome to the Dental Online College and welcome to the series Basic Principles of Oral Surgery. This course is about the surgical treatment of inflammations, incisions, and we're talking abscess. Now, what is in this course? As in every surgery course, we start with basics, we start with the anatomy, we start with basic rules how to assess an inflammation and how to decide when to approach it conservatively and when surgically. We will of course be talking about the incision techniques, about pitfalls and some other things to consider. Allow me to introduce myself. My name is Markus Strolch. I've studied dentistry and medicine in Germany. I've worked in Sydney, Australia and in Zurich, Switzerland. I now received training in maxillofacial surgery, anesthetic and restorative dentistry. Now allow me to come to the basics. Allow me to talk anatomy with you. And if we talk anatomy of inflammations in the oral cavity, it's very often the anatomy of a tooth. It's very often a carious lesion, it's very often from here a pulp infection, and from there derived swelling, pain, and a periapical process. Now if we look at how our teeth are positioned again, from that inflammation of the pulp in the coronal area of the tooth, it has no way to go but to the apex. So it just goes down, and around the apex forms the periapical lesion that we all know. From that point, it can move either vestibulary or lingually, and that is one of the pitfalls already. It's not only the swelling on the vestibular side that we have to check for, you also have to check for the swelling on the lingual side. Now, if we compare that to the maxilla, to the upper jaw, here happens the same thing, of course. The inflammation can go nowhere but up through the roots to the periapical area and either ends up in the canine fossa or on the palatinal side. If you check the oral cavity, the anatomy of it, there's quite some areas where a swelling can hide. So your diagnostic approach has to be very diligent and take some time. That does not only include to look at the things, you also have to palpate through the things. Because if you look at how the structures communicate with each other, especially the tongue area, the floor of the mouth, the pharynx and the throat, very often you run into the danger when you do not treat an abscess or an inflammation in time that it actually can start moving around not only in the oral cavity but in the face or down the neck to the chest area, and then things get very, very critical very quickly. So you want to avoid that on any cost. If we look at this CT scan, here a perimandibular abscess can be seen. And for your convenience, I highlighted it in red. This is the area where we have pus already. So this is the situation where an intraoral approach does not work anymore. Here we have to approach extraorally. So allow me to give you some basic rules for assessing inflammation. Allow me to define the difference between an acute and a chronic inflammation. The acute is more the burning thing, where the chronic inflammation is like the glow that's left afterwards, but it can always ignite into a new fire. So the acute inflammation has the symptoms we all know. It has the pain, the swelling, the red and warm skin, it has the function limitations, and it can have the pus. On the other side, the chronic inflammation can have all these symptoms, but may also not have any of these. It can be totally symptom-free or just have some. Pretty often you can find a fistula, for instance, for a chronic tooth infection as a continuous process, and function limitations can still set in. So if you compare some examples, we have the abscess, the pulpitis, and the acute osteomyelitis on the acute inflammation side, whereas we have the chronic periodontal disease, the tooth with a fistula, or the chronic osteomyelitis on the chronic side of our inflammations. And inspecting the oral cavity, that swelling in this oral area here right now, just by looking at it, is hard to detect. It's on the upper right maxilla here. You're easier off when you use your fingers. Same here. Where is the swelling? Well, it's on the lower right is most of the swelling located. Hard to see, better to feel, or best to combine feeling and seeing. Here you have that fistula on the lower right, combined with the swelling that is already back to the pharyngeal area. And here you again have a swelling sublingually on the left side. Hard to see, palpate it. Now when you palpate it, the patient will also indicate pain if there's an abscess, which makes it a little bit easier for you to actually find these processes. Or here in the vestibulum, it's fairly easy to see here, and it's very close to perforating in this very case. Now, looking at the retromolar area, it's especially hard to see it. Here you have an extensive swelling of the throat, going forward only a little bit. So we have that little bit swelling around the molars, and when you push the tongue aside, then you can see the whole process hiding behind it. One very important tool for you to assess the whole process is the function, is how can the patient actually open his mouth? Is it full or is there a limit? And if there's a limit, is it painful to try to extend further? That's something you want to try. Also, you want to check for breathing and swallowing at this point. Another indication for a possible critical situation is where the swelling is located. Everybody can see in this case the swelling is located at the right side of the face, but what you can also see here is that the lower lid already starts swelling. So the process works its way up. That is something you do not want to ignore. In this case, the patient came with a swelling of the right cheek. And one very important tool to define if it's still a limited process or if it's on its way to spreading out is that you palpate the lower rim here of the mandibular. And you do it with your both hands on both sides simultaneously. That's the easiest way to do it. And you will find that in this case, on the left side, you can feel the rim throughout the whole area. Whereas on the right side, you can feel it at the beginning. Here, when you have the little bar, and where the dots are, you feel the swelling and the patient indicates pain. That is a perimandibular abscess already. Now for this patient, we didn't have swelling. You just had the spreading out infection of the face, and very important, you had a tenderness of the medial angle of the orbit of the eye here. Now if you press that, below that is a vein that actually drains the venous blood from the face back to the skull and is in connection with the sinus system of the brain. When this vein starts to get painful, this patient has to be referred to a hospital for intravenous antibiotics, because that is a possible harmful way, and it's a possible way how this infection can actually spread inside to the brain through the face. So we have certain red flags I would want you to check for and that you have to take very seriously. As soon as you have one of these, the situation is on its way to get critical. Impaired swallowing, breathing problems, limited mouth opening, and tenderness in the medial corner of the eye are the 4 things that you check for in your inflammation patients. Now, when you have such a patient, how do you decide between a surgical or a conservative approach? Well, one thing is the palpation, and that's a very, very important thing. With that, you can find out if the process is hard or soft, if you have a fluctuation, if you have pain, or if the vestibulum or other tissues are elevated. Very important diagnostic markers, because with that you can find out if it's hard, if it fluctuates, if it's painful and swollen, then it's very, very likely that you actually have an abscess, and the only cure for that, well, where you have pus, there you have to cut into it and relieve the patient. On the other side, if the process is soft, if you can't feel any fluctuation, if there's maybe even no pain and no swelling, then you have a process that might be very, very easy to treat with a conservative approach, or which is at least not there yet, not ready for incision yet. As you can see, there might be situations where you have a medial thing between both of them. So actually in this case, sometimes we'll be talking about that, but sometimes you're easier on going for incision because you might prevent things from getting bad. When you see something like this, a fistula, chronic fistula, that's also indication for you that you do not want to cut into this situation right now. Because with that fistula, the pus can flow away and the incision is not that necessary. This is the case for antibiotics. So the conservative approach is endodontic treatment of the teeth, is analgesics for the patient's antibiotics, and very important, cooling. There's another lecture in the series that features especially the antibiotics, so refer to that please for further information. Now, if you have the situation where you have to cut into the process, please take care for anatomically sensitive structures like the nerves, here the mental nerve, or here the lingual nerve and the alveolar inferior nerve. Very important. Now, this is the area where you want to take care, and this is how you prepare your incision then. We love the marginal approach, the marginal incision, because it's very riskless and you get below the periosteum with the first incision. Now here in white indicated marginal approaches, marginal incision techniques that are very easy to perform and that allow you to access that area. Of course, it's also possible, as seen here, to cut in the vestibular area, but sometimes that's not that advisable. So what to use as a standard? As a standard, please use the marginal approach for most situations. As you can see it here, as it's very easy to perform and very risk-free. You see the scalpel going next to the teeth and the sulcus. You see the respiratorium elevating it and going down, and the last step is putting, after rinsing it, then you put in a drainage to make sure it stays open. In this case, the dentist or the patient or both have waited too long. In this case, it's not possible to get into it from the intraoral tissues anymore. Here, an extraoral incision had to be performed with rinsing, and it takes quite some time to heal again. Of course, that's possible also, but still, it's less traumatic to cut inside the mouth. How do you treat these patients postoperatively? You want to see them regularly, want to rinse, and you want to change the drains. So daily recall, rinse and change drains daily, and that is the basic procedures. And as soon as for several days you do not have any pus anymore, you can continue rinsing, but you don't have to put in any more drainage. When all symptoms vanished, then you quit the recall, not before. That is how you treat an abscess patient postoperatively. And when do you apply antibiotics for an abscess? Well, when it's totally localized, you don't necessarily need them. But when it has the tendency to spread, or when it's not exactly localized, then it's sometimes easier to apply antibiotics. And last but not least, of course, the tooth still has to be cared for. Pretty often you can do that with an endodontic treatment, but sometimes you have to sacrifice the tooth and take it out. So what are pitfalls with these procedures? One thing for sure is that the swelling, the pain, does not come from the teeth. The salivatory glands can be infected as well. In this case, it was the parotid gland, and you can see the pus coming through it here. You can see it when you press on the cheek, and then you inspect intraorally, and then you see the pus coming out. Also, there just could be no saliva coming out. Both are indications for an infection of the parotid gland, especially when the pain is localized around here and the vestibulum is not elevated and free and the teeth seem to be intact. Now, these is the congruence we took out in this case, and the approach for a infection of the parotid gland is not surgically. It is antibiotics, drinking a lot, and having a lot of lemon in your mouth as that triggers the salivation. Another critical thing could be you perform your incision, you're happy with that, but just no pus comes out. So what do you do then? Well, here's the protocol. You perform your incision, you think you're there where the whole process was, you just have no pus. That's fine. You have the normal post-operative protocol with the rinsing, with the drainage, as we've been talking about it. You also apply antibiotics and painkillers and cooling. And then you see what happens. You have a daily recall, right? When the patients get better, all is fine. When the patient gets worse, you have to reconsider. So the patient gets better, you continue with your protocol. And on the other side, when the patient gets worse, then you have to refer the patient to a surgeon. And why is that? Well, why do you continue? There are several reasons why you might have no pus and still be successful. If that situation sets in, it maybe wasn't an abscess yet, or there was just too little pus to detect it, or it just gets better although you just didn't hit it and it just sort of caused its own drainage. On the other side, when it doesn't get better, the most likely reason is that you just missed the abscess, or that there's another cause to the swelling and the pain, maybe a tumor even. So that's why you want to refer the patient away then. So allow me to sum up with some take-home principles. Please always check the impaired swallowing, breathing problems, limited mouth opening, and tenderness in the medial corner of the eye. If none of them applies, you're fine. If one of them applies, the situation might be critical. If you're not totally clear whether you should go for incision or not, then pretty often it's pretty smart to go for the incision, as just getting air into it, as relieving the tissue is something that pretty often helps the patient already, and through your rinsing and your drainage, the whole process might be sped up a little bit. Thank you for your kind attention. Thank you for visiting us on the Dental Online College. There's other lectures in this series of Basics in Oral Surgery, and hope to see you there. Thank you very much.